Okay, let's jump right into this deep dive. This conversation is adapted from a really fantastic clinician-written article on Mentalyc.
And we're bringing it to life in audio for therapists who, prefer listening on the go.
Right, maybe between sessions or on that drive home.
This piece was written by Adesua Olajir, LCP, and we're just really excited to feature their perspective here. It's so practical.
It really is. And for anyone who's maybe not familiar, it helps to know Mentalyc is a clinical intelligence platform.
Yeah, it's designed to support therapists with exactly this stuff documentation and clinical workflow.
Which is such a crucial area because let's be honest, documentation can be the most dreaded part of the week.
Oh, absolutely.
I mean, you know that feeling. You're rushing to finish your notes hours after a really demanding session.
A heavy one, yeah. Or just emotionally draining.
Exactly. And you start to worry, are my notes just too vague? Or even worse, did I miss a key detail?
And we all know progress notes are vital, but that whole process can leave you feeling really vulnerable.
Totally. Vulnerable to liability, to claims refusal, or just compromising client care if the notes aren't clear.
That anxiety is so real, and it's why the core insight from Idasu Olashir's article it really resonates. They argue that clarity is a clinical intervention.
I love that framing. It really shifts documentation from being like a chore you have to do for compliance
Right.
to an active part of the treatment itself. So let's unpack that. Let's start with the first mistake the article points to, ambiguity.
Ambiguity, that lack of specificity is really the primary driver of documentation failure.
So when notes are vague,
The miscommunication just ripples out. It affects the continuity and the quality of care. I mean, if another provider has to read your notes, they need observable data, not just your general feeling about the session.
that's where it gets tricky, right? The difference between how we talk in the room, which is full of nuance, and what the record demands, which is measurable language.
Absolutely. The article gives that classic contrast example. The difference between a note that just says, "Client seemed better today."
Which is great to feel, but, I mean, it's useless as proof of anything.
Exactly. Versus the clear, measurable note. Client kept eye contact 80% of the session. He slept 7 hours per night for 2 consecutive nights, an increase of 4 hours from last week.
Now, that shows progress. It's quantifiable.
That's the intervention. It's moving from seemed better to something you can actually point to.
Okay, but can I push back on that for just a second?
Please.
For clinicians, isn't there a risk that if we overfocus on only quantitative data, we, minimize the actual qualitative nature of therapy? How do we capture the nuance of the interaction but still give them the hard data points?
That is a necessary tension. And the article suggests we bridge that gap not by abandoning those qualitative observations, but by rooting them in context and measurable behavior.
So it's not just about counting things.
Not at all. It's about structure. Documenting the exact session duration, yes, but also stating specific symptoms and linking those observations directly back to the client's treatment goals. You have to show why the qualitative observation matters.
And for clinicians who like structured formats, the article brings up BIRP Behavior Intervention Response Plan.
Yes, and the beauty of a framework like that is it basically prevents vagueness by its very nature. It forces you to cover all the bases.
You have to document the behavior, what you did, and how they responded.
Right. And that vagueness often goes hand in hand with some other major vulnerabilities, mainly workflow failures.
Okay, let's group those together then. The article calls them mistake number 2, incompleteness, and mistake number 3, inconsistency.
Yeah, and they totally feed each other. Incompleteness is often a direct result of that rushing we talked about.
You're trying to get it done, so you skip things?
Exactly. You fail to document critical elements, current mood, the specific intervention, updates to a risk assessment, the client's response. It's not just incomplete paperwork. You're risking delayed treatment or mismanagement down the road.
Can you give us a really concrete example of a detail that gets missed but causes huge problems later?
Oh, for sure. The immediate updates on safety and risk. Let's say a client reports passive suicidal ideation early on, but they're stabilized by the end of the session.
Okay.
If the clinician is exhausted and just writes a general note about anxiety management, they might forget to document the full updated risk assessment and the stabilization plan they put in place.
And if that client is hospitalized the next day?
That missing context is a massive liability gap, and it completely compromises continuity of care. The record has to reflect that critical work.
Wow, okay. That makes the cost of incompleteness crystal clear. So what about inconsistency, mistake number 3? That feels more like a long-term problem.
It is. It's insidious. Inconsistency is, switching note formats halfway through treatment, using abbreviations that only you understand.
Or going from super detailed one week to like one sentence the next.
Right. And that undermines your ability, or anyone else's, to track progress over time. It just fragments the client's whole narrative.
It makes the record feel untrustworthy. Like if I'm reviewing a client's chart and the detail is all over the place, I can't tell if the client is getting better or if the therapist just had more time on Tuesdays.
Exactly. The record should tell a story. If the structure is unreliable, the story becomes unintelligible.
Speaking of the story, let's get into the trickiest part. Managing that line between subjective and objective. This is mistake number 4, the danger of subjectivity.
This is so challenging because therapy is subjective. We rely on the client's report, our own clinical intuition.
But the record of it has to be objective.
Professionally grounded, yeah. The article warns about using direct quotes without context, letting personal biases leak in, and this is a common one, ignoring a major mood shift because we assume it's just a temporary thing.
So the key is the distinction between your interpretation and your documentation.
Yes, we can interpret a client's motivation in our heads, but we have to document their words and their observable actions. Avoid making an assumption look like a recorded fact.
The article had a great example for this. The vague assumption was something like, the client displayed signs of depression and a lack of motivation.
Which is a conclusion, not an observation.
Right. And the objective report was grounded in facts. The client reported feeling moody most days. He found it difficult to get out of bed. He started sleeping 12 hours daily and missed work twice this week.
That shift from opinion to evidence is everything.
And that ties into the next one, right? Mistake number 5, assessment redundancy.
Yes, another quality control error. It's what happens when we stop reflecting and just start, copying and pasting.
This is where we see the assessment section get padded with old information.
Or just restating what's already in the subjective and objective sections. It's a time saver that actually makes the notes less effective. The assessment isn't a rehash. It's where you synthesize new data.
And offer new clinical insights based on what's happened since the last session.
If it's redundant, it just forces a reviewer to wade through noise to find the actual signal of clinical change.
So if we pull all of this together, the struggle with consistency, avoiding redundancy, not forgetting crucial details, the common thread seems to be the cognitive load on the clinician. How do we even begin to tackle that kind of systemic exhaustion?
Well, this is where the article suggests a clear workflow solution, which is leveraging technology to handle some of that structural burden.
Okay.
It points out that using AI-powered progress note, taking templates from Mentalyc, can really help clinicians enforce that consistency. It saves time, of course, but more importantly, the templates provide structural guidance.
So it prompts you for the right information.
Exactly. It prevents you from missing important details by ensuring all those necessary elements are included in a compliant format. You're using the AI as scaffolding, basically.
So your brain can focus on the clinical insights, not just remembering where to put the risk assessment update. Quick pause. If the pain points of ensuring structural consistency, managing detail, and dealing with time constraints feel familiar, Mentalyc can help. Its AI note taker supports your documentation and clinical judgment while staying fully HIPAA and SOC2 compliant. You can explore it at Mentalyc.com.
And that brings us to the last core mistake, which is maybe the most forward-looking one. Mistake number 6, the failure to create actionable plans.
This is where that golden thread of care is either cemented or it's totally broken.
Right. The plan section is the blueprint for a future treatment.
And if it's vague, like just writing continued
Monitor symptoms.
Yeah.
It creates confusion. It can affect claims. And it just lacks any measurable direction for the client or for you.
So we need to make plans actionable by making sure they're smart, specific, measurable, achievable, relevant, and time-bound.
Exactly. If the goal isn't measurable, how can you ever prove your intervention actually worked?
The article's examples here are perfect. A weak intervention might be apply CBT techniques.
Which tells us nothing about what you actually did.
But the strong, actionable version is use thought recording exercises and provided worksheets on cognitive distortions. That's clear. It's repeatable.
And it's the same for the goal itself. Reduce anxiety is weak.
So a stronger goal would be
Decrease panic attacks from 3 times a week to once a week within 30 days. Now you have a target, a metric, and a time frame. It moves the whole process into collaborative, measurable change.
And crucially, the plan has to connect directly back to the assessment and the client's objectives. When that golden thread snaps, it's usually right here.
It really is. And if we step back from all 6 of these mistakes, the number one practical tool a clinician has to fight them is just timely documentation.
That age-old struggle to carve out time right after a session. Why is timeliness the ultimate defense?
Because writing notes soon after a session just drastically reduces memory gaps.
Mhm.
Most of the details we lose, the exact quote, the specific mood change, that updated risk factor, it's all lost to time delay,
So doing it quickly ensures you're working with fresh, accurate data.
which naturally promotes more effective treatment planning for the next session. It transforms the note from, like a historical archive, into a living, guiding document.
That's a great way to put it.
Exactly. And maybe we can leave you with this provocative thought. The ultimate purpose of taking the time to write clear, measurable notes isn't just compliance, though that's important. It's about building a comprehensive, evidence-based record that truly proves the effectiveness of the therapeutic process.
So our documentation should stand as evidence.
Evidence that our clinical judgment is sound and our interventions are making a measurable difference in our clients' lives.
If you want support in ensuring your progress notes are concise, consistent, and complete, Mentalyc's AI note taker and customizable templates can simplify your process and save hours every single week. Thank you for diving deep with us today.
Thanks for listening.
We'll catch you on the next deep dive.